Welcome to the PN2 Module 8 recorded lecture on sensory perception. This is the first slide. You're used to seeing these. I'm going to go right through that, and here are the objectives for you. They are in Blackboard if you need to see them, and of course you can print the slides. We're going to spend most of our time talking about the eyes and the ears. There were other learnings that you would have possibly read about in the textbook, but we're going to focus our energies on the eyes and the ears. Starting with the eyes, I'd like you to consider a patient who presents to the outpatient department for scheduled cataract surgery, and pause for a moment and think about what pre-op actions the nurse should take. The nurse would begin the preparation, getting the patient ready to go, taking down health history, verifying all of that in the medical record, checklists that they'll go through. They'll be starting an IV. One of the things that's really important that we assess for is the use of meds for blood clotting. So some of those would include things like aspirin and warfarin or Coumadin, clopidogrel, which is Plavix, the dabigatran, which is Pradaxa. And if we do determine that the patient has a history of taking those medications, it's highly important that we notify the surgeon. These should be discontinued several days before the surgery. The number of days depends on which medication that they are taking. And so one of the first things that you're going to want to do is find out when they took it last, but it's incredibly important, I can't stress that enough, that regardless if it's been 2 weeks, it's important that if it wasn't in that health history that we notify the surgeon that they were on those medications. And then we're going to begin any post-op teaching for this patient as well. Patients who have had cataract surgery are on multiple drops that they'll take. They'll be taking antibiotics. We place those subconjunctival as scheduled. There's a very detailed schedule. I usually recommend writing a written schedule for timing and the order of the eye drops. If there's 2 that are due at the same time, make sure you instruct on how long to wait between each of the drops. And patients are usually discharged within about an hour of the procedure as soon as we determine that they're stable. Some of the instructions in the textbook indicated that they may not have an eye patch on. I phoned a friend who works in ophthalmology, and she indicated that yes, they still do send the patient home with an eye patch, and it should be left on for the first 24 hours. Patients should be instructed to wear dark glasses. The antibiotics are often a steroid antibiotic combination, and so we need to instruct them about any special instructions for those. Let them know that mild itching is normal, but if they're having pain, that indicates a complication. So the itching is fine, pain not fine. We need to make sure that we reduce, or that they do not engage in any activities that can increase intraocular pressure. So we want to reduce that. We need to take steps to prevent infection. So anytime their hands are going to be coming near their eyes, they should do hand hygiene, wash soap and water before they apply any eye drops, or if they have someone assisting them with the eye drops, make sure that individual is washing their hands well. And then of course we're going to assess for bleeding. We would not expect to see bleeding with this procedure. The patient should be instructed to notify the provider of any signs of complications, and that can include things like sharp sudden pain in the eye, any bleeding or increased discharge, swelling of the eyelid. If they notice decreased vision, we would not expect vision to decrease. It should increase over time, or any flashes of light or floating shapes. They definitely need to notify the provider of those. And as mentioned on the previous slide, we're going to instruct them to avoid activities that might increase intraocular pressure. And those include, if you go to table 47.2, there's a nice list of that. You should be familiar with that list. Things that can increase it include bending from the waist, lifting objects weighing more than 10 pounds, sneezing or coughing, even blowing the nose. So we know that if they actually sneeze, it can increase the pressure. So avoiding situations that might cause someone to sneeze would be appropriate. And the same with the blowing the nose. Maybe they have to take an allergy medicine or something to reduce them needing to do that. Things like straining to have a bowel movement can increase it. Vomiting, having sexual intercourse can increase the intraocular pressure. Keeping the head in a dependent position, and wearing tight shirt collars, particularly important for like men who wear business suits, to let them know that if their collars are tight, they might need to leave them open for a few days. And then make sure that you review procedures for use of eye drops, or actually you should review those procedures with the patient. We're going to move on to a new patient who presents to the ophthalmologist with symptoms of headache, mild nausea, sudden blurred vision, and colored halo around lights. And think about what diagnosis you might suspect with this. If you said glaucoma, you are correct. Glaucoma is a common cause of blindness in North America, and it's usually age-related as well. There are couple kinds of glaucoma that you should be familiar with. The primary open angle glaucoma, or they use the acronym POAG. This is the most common form of primary glaucoma, and it usually affects both eyes and has no signs or symptoms in the early stages. It develops slowly, and the patient experiences a gradual loss of visual fields that can go unnoticed because the central vision at first is unaffected. So at times they might have vision that's foggy, and the patient might have mild eye aching or headaches, and later signs and symptoms occur after irreversible damage to the optic nerve function. And these include things like halos around lights, or losing peripheral vision, and having decreased visual sensory perception that does not improve with eyeglasses. So outflow of the aqueous humor through the chamber angle is reduced, and because the fluid can't leave the eye at the same rate that it's produced, the intraocular pressure gradually increases. Now, another type of glaucoma is the primary angle closure glaucoma, or PACG. It's often referred to as acute glaucoma, and this has a sudden onset and is an emergency. And the problem with this situation is a forward displacement of the iris, and it presses against the cornea and then closes off that chamber angle, which suddenly prevents the outflow of the aqueous humor, and so then the intraocular pressure increases very quickly. On assessment with glaucoma, you would note an increased ocular pressure that can lead to tissue necrosis, which eventually causes irreversible vision loss. You may notice a cupping and atrophy of the optic disc. Now, as nurses, we typically don't do that type of assessment, but the provider would see that, and then the patient might be experiencing some blindness. Normal ocular pressure is 10 to 21 millimeters of mercury. As far as symptoms go, patient may experience headache or brow pain, nausea and vomiting. We've mentioned the colored halos around lights, and then sudden blurred vision with decreased light perception. Glaucoma is typically treated with medication therapy. One of the most common ones that is prescribed is the prostaglandin agonist, and examples are here on the slide. The Lumigan or the Zalatan are the most common ones that I've seen. And these medications reduce the intraocular pressure by dilating the blood vessels in the trabecular mesh. What you should know to be able to teach patients, or some of the things you should know, are that the eye color can actually darken and the eyelashes will elongate, which doesn't sound like a bad thing, except if the patient only has glaucoma in one of the eyes, they need to know that they should not use the medication in the unaffected eye, because if they do, and the reason they might choose to do that is so that their eyes aren't slightly different colors, or or I shouldn't say colors, but shades of the same color, and the eyelashes might be longer on one but not on the other, and it's dangerous for them. It is not good for that other eye to have the medication if it does not need it. Your adrenergic agonists, they reduce intraocular pressure by limiting production of the aqueous humor and by dilating the pupil, which improves that flow that we talked about of the fluid to the absorption sites. So they need to know not to take MAO inhibitors, which is an antidepressant. They should wear dark glasses, and they should wait 15 minutes after putting this in before putting in contacts. And some examples that the one I've seen most often is the Alphagan, but there's a list here on your slide of 3 of the medications that fall into that drug class. We also see patients prescribed beta-adrenergic blockers. They reduce the intraocular pressure by limiting production of the aqueous humor and by dilating the pupil, which again improves the flow to the absorption sites. So patients who use this medication need to use caution if they have asthma or COPD. Patients who have diabetes need to check their blood sugar more frequently because this can induce hypoglycemia and actually mask the symptoms. If the patient's on an oral beta blocker, they should check their pulse at least twice a day and then notify the provider if they see consistent heart rates of less than 58. And of course, they should monitor their blood pressure regularly as well. Examples that I've seen most often, I'm looking at this list here. Timoptic is probably the one I've seen the most, but there's a list for you to be familiar with. And then the next one is the cholinergic agonists, and they reduce the intraocular pressure by limiting, the production of the aqueous humor and then making more room between the iris and the lens, which improves that fluid outflow. These patients who are prescribed these medications should be instructed to report increased salivation or drooling, any headache, flushing, or sweating. And the pupil won't dilate to allow more light, so they need to use caution in poorly lit areas. The pupil may not dilate enough to allow light at nighttime, so there's increased risk for injury and falls with that. The last medication type is the carbonic anhydrase inhibitors, and Azopt is the one I've seen the most often of those 2 that are listed there. This medication class directly and strongly inhibits production of the aqueous humor. It doesn't affect the flow or the absorption of the fluid, though. Patients who have allergies to sulfonamides need to avoid these medications. Instruct the patient to shake the medication bottle before applying, and this medication also, if a patient is wearing contact lenses, they should wait 15 minutes after putting the eye drops in before inserting their contacts. Our next patient is an adolescent baseball player who presented to the ED with reports of a baseball hitting the left eye. Which injury should a clinician expect? If you answered a retinal hole or detachment, you are correct. So one of the surprising symptoms is that this patient should have no pain in the eyeball itself. Now, if there was injury to the face, there may be some discomfort there, but there's no pain related to the actual detachment. But what they might experience are some bright flashes of light or floating dark spots in the affected eye. This is going to need surgical care, most likely, and for pre-op care, we need to let the patient know that they're going to do this under a local anesthesia. Until that surgery can happen, the patient should be instructed to restrict activity and head movement. They should place an eye patch over the affected eye, not because of any concerns that the eyeball could have split open and trying to contain the contents or anything like that, but the reason is we don't want to stimulate the eye to have movement. We want to limit the eye's attempt to actually function as it's supposed to. And then there will be some topical drugs to put in, so some eye drops to inhibit pupil constriction and accommodation. So post-op care is going to include an eye patch and a shield over the eye, and we're going to monitor the patch for any drainage. And then positioning will be per the surgeon's instructions. Patient teaching is going to include, as we mentioned, if the surgeon's going to let them know what position their eye should be in. So if they used any gas or oil was placed in the eye, the surgeon's going to ask that they keep that head probably in an upright or like in a recliner kind of position for a time. The patient should be instructed to report any sudden increase in pain or any pain with nausea. We need to instruct them to avoid, again, activities that increased intraocular pressure. Again, you can go to table 47.2 to get a list of that. We need to instruct the patient to avoid any reading or writing or any close work such as sewing or those types of hobbies in the first week after surgery. These tend to cause rapid eye movement, which can impede the healing of the repair that was done. Patients should be instructed to report any signs of infection and then report any decrease in vision acuity or pupil that does not constrict in response to light. I want to discuss two other retinal disorders as we're wrapping up the section on the eyes. The first one is macular degeneration, and this is the deterioration of the macula. That's the area of central vision, and it can be age-related or exudative. Age-related macular degeneration, which they abbreviate AMD, has two types. The dry AMD is caused by a gradual blockage of retinal capillaries, allowing the retinal cells in the macula to become more ischemic and necrotic. The central vision declines over time, and the patients describe mild blurring and distortion at first, and eventually the patient loses all central vision. And interestingly, my father's wife, her mother had macular degeneration, and she has it as well. And my father was telling a story that he was driving down the road, and there were little children playing along the side of the road, and he said to her, "Keep an eye on those little kids over there, because I'm afraid they might run in the street." And she looked over there at the kids where he pointed, and she said, "What little kids?" And so it was really sad because she knew where to look, but because her central vision was affected, she couldn't see them. And so then over time, even the peripheral vision, you can see shades of light and dark, and it's a very, very difficult disease process for people to experience. Their lack of independence. I can tell you that the house that she kept 10 years ago was immaculate, and when I go to visit now, I can see signs that she's not able to maintain her home the way she'd like to. And it's not because she physically can't do it. She can. She's very mobile and all of that. She just can't see to know that it's not how she used to keep it. And it would break her heart if she knew that that her house was in the condition that it is in some places. So we don't tell her because it's not her fault. And sometimes I do a little cleaning when I'm there. So with the AMD, there's no cure. They have found that they can slow the progression by taking specific multivitamins. They say the risk for the dry AMD can be reduced by increasing long-term dietary intake of antioxidants, vitamin B12, and the carotenoids lutein and oh, this is a tough one. So the lutein is spelled Lutein, and the next one I'm just going to spell it for you. It's Zeaxanthin. Zeax. I don't even know how to start, so you can have a good laugh with me on that. So the second retinal disorder that I want to discuss is the retinitis pigmentosus, and this is a condition in which retinal nerve cells degenerate and the pigmented cells of the retina grow and move into the sensory areas of the retina, which causes further degeneration. And what happens because of this is night blindness. And often people who have this condition start to experience that night blindness as early as childhood. You don't need to know a lot about that, just wanted you to be aware. Now we will move on to disorders of the ears, and let's talk about a patient who presents to the urgent care with reports of having a cold for the past week, a fever for 2 days, vertigo, and ear pain. Which condition might you suspect? If you stated otitis media, you are correct. And signs and symptoms of otitis media include ear pain, conductive hearing is reduced, tinnitus can develop, so ringing in the ears, headaches, malaise, fever. Patients often experience dizziness with this. If you do an otoscopic exam, you're going to notice a bulging tympanic membrane. Will be reddened, thickened, and you may even be able to see pus behind the membrane. With progression, if it's left untreated, you might see a perforated tympanic membrane as well. Treatment priorities include antibiotics, and usually it's oral antibiotics, though I have heard of times when they have put eardrops in as well. Analgesia for pain and for fever, so aspirin, ibuprofen, and acetaminophen. Of course, we want to use caution with using aspirin with children. And then an antihistamine and decongestants can often be prescribed because they will help to decrease that fluid in the middle ear. Patient teaching includes completing full antibiotic therapy as prescribed. We know that that is always a major concern when we give antibiotics. And then if your patient is experiencing vertigo or dizziness, we want to instruct them to change their position slowly. The next patient that we're going to discuss is a 33-year-old male who presents to urgent care with symptoms of tinnitus, sudden right-sided hearing deficit, and vertigo. Based on some of the topics you should have noted in your reading, what do you suspect he has? Meniere's disease most often affects men between the ages of 20 to 50 years old, but can also affect women as well. Signs and symptoms include tinnitus, one-sided sensorineural auditory deficits, can also include headache, feelings of fullness of ear, hearing loss, vertigo. The vertigo may be accompanied by nausea and vomiting and rapid eye movements, and even severe headaches. Patients are almost totally incapacitated during an attack, and the recovery can actually take them several hours and even days to recover. The pathophysiology of Meniere's disease is an excess of endolymphatic fluid that distorts the entire inner canal system, and this distortion decreases hearing by dilating the cochlear duct. It causes vertigo because of the damage to the vestibular system, and it stimulates tinnitus. At first, hearing loss is reversible, but repeated damage to the cochlea from increased fluid pressure can lead to permanent hearing loss. People who have this, again, when they have a flare of it, they are incapacitated. They're often in bed and can't do much else until it passes. Our primary concerns for these individuals are safety and comfort. Treatment includes pressure pulse treatment or a labyrinthectomy. Patient will be placed on a low sodium diet, and drug therapy could include mild diuretics, antihistamines such as diphenhydramine. They may be on anti-vertigo agents or antiemetics such as meclizine. They may do an intratympanic therapy with gentamicin or corticosteroids to try to resolve this for the patients as well. We're going to discuss the Weber and Rinne hearing test. The Rinne test is a hearing test primarily for evaluating the loss of hearing in one ear or unilateral hearing loss, and it compares perception of sounds transmitted by air conduction to those transmitted by bone conduction through the mastoid bone. Thus, one can quickly screen for the presence of conductive hearing loss. The Rinne test should always be accompanied by the Weber test to also detect sensorineural hearing loss and thus confirm the nature of the hearing loss. The Rinne test is performed by placing a high-frequency vibrating tuning fork against the patient's mastoid bone and asking the patient to tell you when the sound is no longer heard. Once they signal they can't hear it, quickly position the still vibrating tuning fork 1 to 2 centimeters from the auditory canal, and again ask the patient to tell you if they can hear the tuning fork. The air conduction should be greater than the bone conduction, and so the patient should be able to hear the tuning fork when you place it next to the outer ear, after they can no longer hear it when it's been held against the mastoid. If they're not able to hear the tuning fork after the mastoid test, it means that their bone conduction is greater than air conduction, and this indicates that there's something inhibiting the passage of the sound waves from the ear canal through the middle ear apparatus and into the cochlea. So therefore it's a conductive hearing loss. In sensorineural hearing loss, the ability to sense the tuning fork by both bone and air conduction is equally diminished, implying that they will hear the tuning fork by air conduction after they can no longer hear it through bone conduction. And this pattern is similar to what is found in people with normal hearing. But patients with sensorineural hearing loss will indicate that the sound has stopped much earlier. This can be revealed by the investigator with normal hearing, placing the fork close to hers or his own ear after the patient indicates that the sound has subsided, noting that the sound from the fork is still loud and clear to a normal ear. With the Weber test, the tuning fork is, you strike the tuning fork and then you place it on the top of the head, and the patient should have equal hearing from both sides. Just as a note, the sensorineural hearing loss is damage to any part of the specialized nervous system of the ear, and sound is heard best in the normal ear. The conductive hearing loss will hear best in the actual abnormal ear. Another test that's not listed on this slide that you may be called upon to perform is the Romberg test, and this is given to a patient who has a problem with proprioception or somatosensory perception, and determines that they can still maintain balance by compensating with vestibular function and vision. In the Romberg test, the patient stands upright and is asked to close his or her eyes, and a loss of balance is interpreted as a positive Romberg sign. And this concludes the recorded lecture on sensory perception, focusing on the eyes and the ears. We'll have some activities in class to help reinforce this, and have a great week.